Hi, everyone. Thanks so much for joining us today. My name is Tara Kolk, and I'm the project coordinator for the Southeast Mental Health Technology Transfer Center School Mental Health Initiative. We are so excited for today's learning session that will provide an introduction to measurement-based care for more personalized, collaborative, and effective school mental health interventions. Throughout the session, if you have any audio or technical issues, feel free to use the chat box or email me directly and just find a way to communicate with our team so we can try to assist you. Also, we encourage you to share any links you might have to resources in the chat box and engage with us through the chat box in all the ways. All right, so I'm going to read a quick disclaimer. The views, opinions, and content expressed in the presentation do not necessarily reflect the views, opinions, or policies of the Center for Mental Health Services, the Substance Abuse and Mental Health Services Administration, or the U.S. Department of Health and Human Services. And for those of you who are not familiar with the MHTTC network, I will give a brief introduction to our center. Today's session is brought to you by the Southeast Mental Health Technology Transfer Center, or the MHTTC for short, and more specifically, the School Mental Health Initiative within the MHTTC. We are located in Atlanta, Georgia at Emory University's Rollins School of Public Health, and we are proud to serve the 8 states in HHS Region 4 that you see pictured here in blue. Our center includes faculty and staff with expertise in public health programs, finance, policy, and health systems. And this provides us a unique lens through which we can address mental health priorities in our region. The goal of our center is to accelerate the adoption of evidence-based mental health programs and practices by providing training and technical assistance to Region 4. On the next slide, you'll see a screenshot of our website. Sarah Trello, my colleague, will plop that link in the chat box for you to visit our website and find more information about our center, about our upcoming trainings, and see some archived recordings of our past trainings. And I'm very happy to introduce Dr. Elizabeth Connors. She is an assistant professor at Yale University and a faculty member with the University of Maryland National Center for School Mental Health. Dr. Connors received her PhD in clinical child and community psychology, and her work focuses on improving access to high-quality mental health promotion, prevention, and intervention services, and supports for underserved youth and their families in critical access points, such as schools and community settings. And I will hand it over to you, Elizabeth.
Thank you so much, Tara, for the framing and the wonderful introduction. I'm so pleased to be here with you all today for our virtual learning session on one of my very favorite topics, measurement-based care. It is awesome to see all the introductions coming through the chat. So please continue to introduce yourself with your name, your organization, and your state. It's always great to see strong representation from the Southeast region, as well as people who are calling in from all over the country. So it's great to see that we've got folks from a lot of other regions represented today, and we welcome you all here. So here are learning objectives for today. We are hoping that you will leave today's session with an increased understanding of measurement-based care, what it is and how it's valuable for improving and sustaining our high-quality school mental health services, particularly at that early intervention tier 2 and treatment tier 3 levels of support. We want you to have increased familiarity with specific measure or assessment options that you can use, that you can go to, and a little bit on best practices for training and implementation support. These virtual learning sessions are always designed to promote cross-state networking and shared learning about the best practices that you're seeing on the ground. What are your successes? What are your challenges? So we invite you to ask questions and contribute what you've learned from your systems throughout the VLS. You can do that in the chat box. We love seeing an active chat happening throughout, and you're also welcome to raise your hand at any point on Zoom, and we can call on you so that you can contribute aloud. And please also, if you have video enabled, we love seeing folks' faces. And so if you're willing to be on video today, we would really welcome you to join us in that way as well. Okay, so this is what we're going to cover today. First, I just want to give some basic foundational information about this term measurement-based care and talk about the research evidence that's supporting this practice at this point. We're then going to talk about its value in schools. I promise we'll tell you about free and low-cost measures. I feel like that's one of the questions that I get very frequently is, what can we use? And then I have a district example of implementation to share with you. So first, let's ground in this definition of what measurement-based care really is, and I will also use interchangeably the acronym MBC throughout. So MBC is the routine collection of patient-reported progress measures throughout treatment to guide clinical decision-making. So there's a few things to notice here about this definition. We're talking about routine collection of measures. So this could be every session, as frequently as every week or every other week, but we're not talking about data collection on a quarterly or semi-annual basis. This is something that you're doing quickly, but as a matter of habit and routine every time or every other time you're seeing a young person with or without their family. And we're using those measures. So this is not a practice where we're collecting data for accountability purposes or to put data into a black hole. We're really using what the student or the parent is telling us on the measure in real time to get a better understanding of their subjective experience of progress and to really incorporate that in our session with them. And we use the information they're sharing with us throughout the entire course of treatment or intervention to guide our clinical decision making so that we can have a signal when it might be time to change things up, or if there's a signal that we're on the right path and we just need to sort of keep at this. So usually when I talk to folks involved in school-based mental health, this term measurement-based care is relatively new. So if you're brand new to this term, you're not alone. And in fact, this term has many sister terms, which you're probably more familiar with, like data-driven decision-making. This is also a practice very consistent with response to intervention that we tend to do on the academic side of things in our multi-tiered system of support. There's a lot of other terms like progress monitoring and feedback-informed treatment, evidence-based assessments. There's a lot of different terms that are out there in the practice world and in the research world. MBC really is the predominant term that's being used right now and is being used in a lot of the research literature that's collecting evidence to support this practice. But it's important to know that it really does come out of the health and behavioral health care space. So some of you that are more aligned with kind of the behavioral health system world may be more familiar with this, and admittedly it is quite new to education. But the reason we're having the VLS today on this topic is because this practice does have very strong evidence base at this point and is highly transferable to help us ensure that our tier 2 and tier 3 services are of high quality, that we can track what's happening in those services, and perhaps most importantly, that down the line we could actually report out on the impact of the services that we provide to children and their families in schools. So when you think about this practice overall, it includes the initial assessment where you would collect perhaps a number of measures to really understand what's going on with the student who's been referred for services. You have to then use that information in conjunction with what they're telling you subjectively and your clinical judgment to specify what is the target problem or what is the target goal. You then set whatever your intervention plan is going to be to meet those needs, and then we're monitoring treatment progress throughout. So all too often in our interventions, both in clinical settings and also in school settings, we might do the initial assessment piece, and that tends to be where we see a lot of measurement happening. We are going to define the problem, collaboratively often with the student and the family and perhaps also with teacher input. We set our goals, we get on our intervention track, and somehow we forget to come back and do some reassessment with progress monitoring, right? So measurement-based care is really reminding us that we need to be explicitly monitoring treatment progress throughout. So a lot of times people will ask me, well, what does this actually look like in schools? So help me kind of put it into like a school services tier 2, tier 3 frame of mind. So here are a few examples that may be helpful for you to orient, and this is based on some vignettes that my team and I developed for some implementation research we're doing. So if you want to check out the full description of these vignettes, there's a link here for you on the slide. But here's a few examples just to kind of get you thinking about what this practice might look like in schools. So let's say you have a 9th grade student with an individualized education program receiving special education for ADHD combined type. For this student, you might use the Vanderbilt assessment to confirm that diagnosis, but then you might use pieces actually of that Vanderbilt to monitor progress over time. With this student, you might review weekly and discuss both with Terrence and his mom how organizational strategies are going, if that's part of your intervention plan, to really help him with organizational strategies, as well as looking at sort of daily agendas that he may be setting for himself and tracking homework that's turned in. So your progress monitoring could actually be checking in on his daily agenda setting and tracking homework being turned in. So those could actually be your progress measures. Whether or not you decide to continue using the Vanderbilt, every time you see one another, that's a pretty long measure to be checking in on frequently. So you might pick some other more brief progress measures that are very individualized to what he's working on to make sure that you have a concrete way to track progress. Another example here is a 3rd grader, Christina, that has post-traumatic stress disorder. In this case, a great measure to use to confirm that diagnosis would be the UCLA PTSD index. There are others, but this is just one that you could use. And let's say with her, you're really focusing on coping skills and sleep hygiene, particularly if one of the symptoms that are really bothersome to her are nightmares and disruptions of sleep. So you could track nightmares and you could track coping skills as your progress measures and use that to discuss sort of how those interventions in those arenas are really fitting for her. You could re-administer the UCLA PTSD index at an interval that feels right to you and the family. You could also take just the symptom questions out of that and use the symptom questions for ongoing progress monitoring to make it a little bit briefer. The third example here is Tyler, who's a 6th grader with some anger outbursts and declining grades. This is a student who's referred when he has had his family is going through a separation, his parents are going through separation, and teachers are noticing that there are some differences in his behavior and some impacts to his grade. So you might not have a clear sense right out the gate of what might be going on with Tyler. The strengths and difficulties questionnaire is a really nice global measure to get a sense and of a little bit more kind of pinpoint what might be going on for him as part of your initial assessment and treatment goal setting. Let's imagine this is a young man that doesn't really want to talk to you and is not very open with you about what's happening in his life, or may not have a lot of insight about how what he's been experiencing in the community or in his family system are impacting his grades and his behavior at school. So maybe your focus with him is really on trust and relationship building while you're continuing to get kind of progress monitoring reports from the parents and the teacher. Many people actually use working alliance, very brief working alliance measures as part of their regular check-ins with adults and with children. So let's say you want to use the session rating scale, which is a 4-item kind of satisfaction with treatment and working alliance type of a scale to check in with Tyler as you're working to kind of build that relationship with him so that he may feel more comfortable opening up to you and kind of sharing with you how things are going. So you can see from these examples that the intention is to pick a progress measure that's really matched to what it is the young person is working on. And you are welcome and encouraged to individualize that in a way that makes sense, but that you have some kind of standardized, structured way to check in and get some quantitative feedback and data throughout the intervention process. So measurement-based care is part of an evidence-based practice orientation. The APA Task Force on EBPs with Children and Adolescents tells us that when we have an evidence-based practice approach to service delivery, there's 3 real components to that. The first is conducting assessment that informs our initial diagnosis, our treatment planning, and our outcome. Of course, we need to have an evidence-based intervention and making sure that our interventions are effective for the people we're serving, and then also having ongoing progress monitoring. And it seems as though in regular practice, it's really this third piece that's met with a lot of barriers and challenges. And MBC really focuses on the assessment components of an evidence-based practice orientation. The other thing that I'd just like to point out here really quick is that measurement-based care is basically a little measurement routine that you can add into whatever intervention plan you have. So research has been done with MBC across a wide variety of different types of presenting concerns, age ranges, different types of interventions, diagnoses, children, adolescents, couples treatment. So as a provider, as a mental health clinician, you really have all the latitude that you want and need to design an intervention that makes sense for the young person in front of you. MBC is really agnostic to the intervention planning component. What MBC does for you is it gives you some signals about how that intervention is going throughout the course of treatment, right? So that we don't just press go on our plan and not check back in until halfway through the school year or at the end of the school year, but that we're really having sort of a data-driven component built in so that we can check in on how effective our intervention is throughout the course of that being delivered. So one of the most helpful and really practical clinical explanations of MBC that I've found is actually developed by some colleagues here at Yale of mine, Dr. Sandy Resnick and her team, who have led the National Veterans Affairs MBC rollout. And there's a large kind of national MBC and mental health initiative that the VA has taken on for veterans and, adult populations. And in this model, MBC is described as having 3 core components: collect, share, and act. And I really like this because it gets to the heart of what needs to happen in this progress monitoring part. It's not just the data collection part, right? It's not just filling out that measure or looking at that homework log. It goes beyond that to really make sure that we are referring to and sharing the results in real time with the student and the family. Ideally, right after the measures are completed, we need to be explaining their meaning and discussing whether they actually match the student's subjective experience or the parent's subjective experience. And then to make sure that we're acting on that together in a really collaborative and transparent manner, that we're having a conversation in the moment about, how we're evaluating that progress, and that we're generating possible adjustments to our approach when that's relevant, so that we can engage in some shared decision-making to select the best option together. So when done well, this is a really collaborative, patient-centered practice. It can be applied to any treatment plan, as I said, or setting or presenting concern. And all of this collect, share, act can happen in the first 5, even 10 minutes at the very most of your interaction, of your session with the student. So instead of just sort of or maybe in addition to sort of an open-ended question of how somebody's been doing since the last time you've seen them, you can use the quick collect, share, act model to enhance that rapid engagement, make sure you're getting their ratings on something concrete, you're checking in on their progress on some sort of concrete metric, and then asking them, you know, how does this look to you? Is this consistent with how you're feeling right now? And what does this tell us about the work we've been doing together? Are we on the right track? You know, we've been focusing, for example, a lot on your organizational skills. Or we've been focusing on, you know, how to get to bed on time at night. Or we've been focusing on what your relationship's like with your mom. Does it seem like, based on what you're experiencing, we should continue working on that? Or is there something that we should change up, right? So really just adding a quick 5-10 minute measurement routine to the beginning of the session to make sure that we are giving that voice to the student and the parent, if they're involved, that we're working with, and say, hey, you know, we want to know from your vantage point how things are going before we dive in. We don't want to miss anything, right? So let's just do our quick check-in. And so it's transparent, it's collaborative, it's student-centered, it's giving them autonomy and voice, and it's going to give you a little bit more of a data-driven approach to the work. So just a couple words about the research evidence that I think is important for us to know. There have been, at this point, there's sort of a proliferation of studies supporting measurement-based care, and there's a considerable body of research with rigorous large-scale designs and meta-analyses that are supporting the effectiveness of this practice. I will say is primarily with adult populations, although there is a lot of growing research with children and adolescents, which I'll show you next. And generally what we see is the effect size of these studies when looking at measurement-based care compared to treatment that doesn't involve measurement-based care, we see effect sizes of about 0.28 to 0.70. That's a pretty wide range, but it's also pretty high. I mean, this is in the same realm that we see evidence-based treatments that come out of randomized controlled trials. So when you dig into that range, the moderate range of effect sizes we see are for our cases that are not on track, meaning that MBC really helps us have an early signal alarm for kids that may not be progressing as we would expect. So, you know, sometimes you meet those students and they are just so motivated and they go through kind of the first intervention sequence that you have planned for them, and they're doing all their homework and they're meeting all their goals, right? And I don't know about you, but when I was working in schools, that was maybe a quarter of the students that I saw, right? And then you've got another proportion of students for whom you can change things all the time, and it's hard. It's really hard to help them make progress. Then you've got some other students who just are not making progress the way you'd expect, and you can't figure out why. So what we've learned from looking at the studies of MBC is if you've got somebody who's off track or not progressing the way we would expect, this practice is going to give you an early signal alarm. It's really going to improve your clinical judgment to be able to make sure nobody's slipping through the cracks. It's going to give you a sense earlier on of when you can make adjustments to the treatment to improve their outcomes. And that's where we see the real big effect sizes with measurement-based care. We also know that feedback should be provided not just to you so that you can see the results of the assessments, but to the client. So whether that's the student or the family, it's really important that they are viewing that progress and that conversation is happening in the room. When there's clinical support tools provided so that you have an idea of how to adjust your intervention plans, that's also very helpful. And when measures are actually used to make changes in the treatment plan, which is the whole idea. So here's what we know about this practice with children and adolescents. It is, you know, this research is relatively less developed, but there's a recent review that identified 14 studies looking at the effectiveness of MBC with youth, and many were actually conducted in school settings as well as individual therapy or group therapy. And what they're seeing is better and faster symptom improvement. So it definitely mirrors what we've seen in adult populations, definitely decrease in psychological distress. Interestingly, we've seen that improvement might occur based on the child report, the parent report, the therapist report, or some variation on that. which I think is a good signal to us that we need to get multiple reporters, and we all sort of know that intuitively, but sometimes the parent will say things are not going so well, but your student is saying things are fine, right? So we kind of take all of that as different bits of information to really inform our picture about what's going on. We also see that there's a dose-dependent improvement in outcomes, meaning that the more often clinicians collect these measures and view the results, the more the children and adolescents improved. So I don't have a real clear, people will often say to me, how often do I really need to be collecting these measures, right? Because it is a little bit of a routine that you need to add in to your workflow. And the truth is, we don't really know. We know that quarterly's probably not regular enough. This needs to be enough of a routine that you can make real-time adjustments. But we do know that the more often you collect these measures, the better your students will get. Your student outcomes will be better the more often you collect this. So frequency matters. We don't have enough research yet to say exactly what that frequency is. But every week, every other week is usually what people are looking at in these studies. So some of the elements of value hopefully are clear to you at this point, but I just want to underscore a few of these things. We've talked about the improvement in student outcomes that you can get from this practice. This is a personalized, individualized treatment approach. It helps you stay really close to what the student's experience is of interventions and how different things are impacting them in their lives. It helps with shared decision making. So, for those of you who are really invested in authentic engagement and partnership with your students and families and teachers, if they're involved in this practice, this is really a concrete way that you can make sure that you're sharing that power in the clinical relationship with shared decision making and really elevating student voice and parent voice. It also gives you great data-driven signals of students who are off track. And the research has shown, unfortunately, our clinical judgment is not always as accurate as we would like it to be. And so when we integrate a little measurement routine in this way, it really does improve the accuracy of our clinical judgment. So I hear a lot of concern often in schools about engagement, and I think that there are a lot of really good reasons why that's a particular challenge in schools that doesn't show up quite as much in even community-based clinics, where by definition, parents typically have to transport their children there, and they have to overcome a lot of logistical barriers to get to clinic in the first place. So just by nature of working in school systems and really improving access to mental health care, sometimes there's a trade-off in that we've got to work a lot harder around the engagement and partnership aspects. So just know that MBC is absolutely a practice that can help you in this arena because it improves our communication, working alliance. It's been shown to retain clients in treatment longer. Clients who have measurement-based care as part of their services report a greater sense of involvement in therapy. They get the clear message that their perspective matters and they're involved and it's really centered on them. And there's also research that shows that clients become over time actually more attuned to their own symptoms and their functioning and their experience because we're building a habit for them too, right? To kind of identify and self-report and reflect on how they're doing each time we meet with them. So it provides some structure and some grounding, but we're also building skills about insight and attunement to their own symptoms. And, for children, adolescents, I think this is so critical because one of the first steps often with them is to make sure that they have they're growing their emotion identification skills and they can identify and express what their emotions are and what they're going through. So adding this practice in also scaffolds those skills and that development that you might want for a lot of the young people that you're working with. So MBC in schools, to me, is a really easy fit, and there have been, well, I won't say easy, but a very logical fit. There are certainly some barriers that I think we overcome anytime we're implementing something new in schools, but this is a very, very compatible practice with the work that you all are providing, particularly at that tier 2, tier 3 level. We know that schools deliver more mental health treatment to children and adolescents than any other child serving sector. The proportion of services received in schools is huge. So being able to incorporate, practices like this that are very evidence informed, but can be applied to a wide variety of student ages and presenting concerns makes very good sense in schools, just to make sure that we're elevating the quality of what children and adolescents receive. We also know that schools love data. The education system loves data and data-driven decision-making approaches to make sure that we're being very judicious and targeted about how we're meeting student needs. So if you're in school systems that are big on RTI, progress monitoring and feedback, data-driven decision-making, this is probably right up your alley. Oh, I see. Alexis asked a great question in the chat, and please let me know, folks, if I'm missing anything in the chat. Alexis asked whether I think it's better for progress monitoring for weekly or bi-weekly. That's such a good question, Alexis. So the standard that you will see most often is weekly progress monitoring. If you're meeting with a student more than once throughout the week, it might feel like too much. But I do know of programs like partial hospitalization programs. For example, there's an adolescent PHP here at Yale that's very intensive, and they do daily progress monitoring with their young people at a really high level of care. So I think weekly is the best. It's probably the gold standard. If it feels like too much to the student, to the parent, or to you, you should have that open conversation and talk about the frequency. Because if you don't need to do it every week, or you feel like you're like on a really good trend, like this intervention is really working, we know we're right on track, maybe we just check in every other week. I don't think you want to go less frequent than that. I would start with weekly as kind of a starting place in a matter of routine, and then revisit frequency depending on how that feels. Great question. So there are a number of engagement and other sort of effectiveness and sustainability benefits of MBC in schools. And so I have this slide here in case it's useful for you, as you may be in the position of sort of messaging this to others in your school system or in your system, like, why should we be doing MBC? Like, what's this about? So here's kind of the 4 high-level reasons why MBC is a great idea. Empowerment, that it certainly centers student and family voice. Transparency, that we are clarifying our goals for intervention and evaluating progress together. I've heard empowerment come up importantly in schools recently in a number of ways, particularly around sort of cultural responsiveness and equity, and making sure that we're staying very aligned with our interventions in a way that makes sense for what students and family want. And then transparency has come up a lot in schools, because sometimes we move forward with interventions without a lot of clarification on what our goals are. Or maybe sometimes in the case of special education, you may be handed IEP goals, right, that maybe haven't been revisited or clarified in a while. And sometimes there's actually not a lot of clarity on how we're going to even measure progress, right? And there's been some writing in the literature about how that can inadvertently really perpetuate mental health stigma. Because if we're not tracking progress in a transparent way, and we're not able to sort of demonstrate how we're evaluating progress, the student doesn't know how we're evaluating progress, the parent doesn't know how we're evaluating progress, kind of makes mental health treatment seem like a little bit more of a black box, right? Because nobody's able to get a handle on kind of how we're doing. Are we at the beginning, the middle, the end? You know, is a student ready to graduate services, or how much better are they doing now compared to when we first started working with them? So the transparency around this is helpful for all stakeholders. Certainly infuses a lot of effectiveness and quality to your tier 2 and tier 3 services by making them more data driven. And then eventually, as you work through implementation of this practice and scaling up this practice, you can very much leverage this to track and communicate the impact of your tier 2 and tier 3 interventions. You know, I would say, based on my experience working with a number of school systems at this point who have implemented MBC, I would not lead with the expectation that you can communicate the impact of your interventions in the first school year that you're taking on MBC, right? We need to stay focused on the core purpose of this practice, which is to elevate the quality of our services. It's really about that student, clinician, parent interaction, making sure we have data-driven signals. And then after that practice is really well integrated into our system, we can start conversations about measures that maybe are collected across clinicians and how we can leverage those measures in aggregate to communicate the outcomes that we're seeing. So it absolutely can be a pathway toward messaging impact and sustainability. But I just always put that caveat in there so that we are managing our expectations around the implementation of this, and that, you know, you really have to kind of work on the implementation and keep the student and family centered piece in kind of the short-term goal, and knowing that sustainability is absolutely the long-term goal. So some of you may be familiar with the performance standards that appear in the National School Mental Health Best Practices Implementation Guidance modules. There's a number of sort of national school mental health quality indicators to which many of us ascribe to and aspire to in our work. And so I do want to point out that there are national performance indicators of school mental health quality that MBC promotes. So if these are the types of indicators that your system cares about and you're really trying to work on and you feel are priorities, MBC is absolutely a practice pathway toward them. So there's an indicator here about ensuring that your intervention goals are SMART goals. I've found often that in implementing MBC, it really raises questions about what is our SMART goal? What are we after? Because we cannot pick a progress measure unless we're really clear on what our goal is with a young person. MBC is also helpful for us monitoring individual student progress as we're using different data sources and reporters to ensure that our progress monitoring data is really aligned with what we're doing and that there's feedback being provided. And then these are all of the indicators in the impact domain, which often when I work with school systems, they say these are some of the most challenging performance indicators to tackle, is how we even start to report out on our impact. You know, who are our students receiving tier 2 and tier 3 services? How are they doing in terms of their functioning in different domains? And how can we sort of start to aggregate and also disaggregate those data to understand the impact of our services and the sustainability elements of those tiers? So I've just told you all these great things about MBC and its compatibility with schools. And you might be wondering, well, this must just be easy, right? There must be an easy button here. But I know that there often are barriers encountered to implementing MBC. And so I'd just love to hear from you all on the line. Feel free to type in the chat or raise your hand. What barriers have you encountered? Or maybe if you've done really tried to do any progress monitoring for tier 2 and tier 3, or if this is something that you have been talking about in your teams that you want to do, what's getting in the way of this practice? What comes up for you? Or even as you're hearing about this, you might be foreshadowing some barriers. What barriers are you worried about? What would get in the way of you being able to do this, next week? Great. Alexis is noting concerns about parents and teachers not participating or giving feedback. And Tonisha is mentioning finding assessments. Yes, those are very common barriers that I hear. Competing priorities and buy-in, absolutely. So you all are stacked with all kinds of asks in your workflows. Knowledge and training for school counselors, what their roles are. Yes, so am I the one that would be doing MBC, right? We have very multidisciplinary teams in school, so understanding sort of whose role this is. Time for completion, parent participation, the paperwork that may be associated with tracking these assessments, what assessments are actually available, and how we can pick tools that match the goals of the intervention. Stakeholder buy-in, finding the right assessment. Cost, yes, thank you, Miriam, for bringing that up. Right, and there's also a question about should MBC be incorporated with other programs, like if you're doing trauma-informed care, if you're doing community schools, right? Amazing. So these are all very on point. Yes, Alexis, I've got assessments coming up, I promise. These are all very on point barriers that we hear very commonly. And I just want to put a plug in and say that I know the Southeast MHTTC is very open to doing a part 2 on this topic. So if you don't get all the information that you need at the end, and actually I'll do an all call at the end for you to type in what more info you want, we're very happy to do a part 2 because we know today might be really kind of setting the foundation and talking about this practice, but I can tell from your comments, there's a lot of sort of detailed questions about implementation, which I'd love to get into with more with you. Great. Brittany's voting for a part 2. I love it. Okay. So just so you know, we, in general, fewer than 20% of clinicians report doing this. So if you're not doing it in your practice right now, you're not alone. We did a national survey of school mental health clinicians several years back, and they raised a lot of the barriers that you just raised now in the chat. So as I have mentioned, you can incorporate different kinds of measures for your progress monitoring. We usually think first about these standardized measures. These are the ones we're familiar with. They've got standard items, usually these Likert style response options like strongly agree to strongly disagree. They're usually symptom questions. They ask about specific symptoms. Sometimes we actually see standardized measures that are like working alliance measures. So there are exceptions to this, but they're usually kind of symptom checklists. They often will have norms or clinical cutoffs to help us interpret individual progress in relation to what would be expected to sort of a larger population. They can be global, like the strengths and difficulties questionnaire I mentioned earlier gets at internalizing and externalizing concerns, or they can be problem specific, like the PHQ-9 is just for depression. Please know that you can also incorporate individualized measures. There's some research that tells us that clinicians actually prefer sometimes individualized measures, but they don't think about them as part of sort of legitimate progress monitoring measures, but they absolutely are. And we know that in schools, these individualized measures tend to be more popular. Just make sure that you have a consistent way that you and the student and the parent all understand how we're tracking these things so you can make them a little bit more quantitative. And so, for example, if you're going to set a goal, you can use something like a top problems or top goal rating, where you're actually putting that goal on a scale of 0 to 10. And you talk about, well, what does it mean if you were at a 0 for this goal? What does it mean if you were at a 10 for this goal? And helping the student and parent kind of put together a little bit of a way to rate what that individualized measure is. So this could be a whole host of different things. It could be also problem or goal specific, but skills logs, days absent, mood ratings. For those of you who do anxiety work, sometimes we use subjective units of distress, which is kind of a version of an anxiety rating. These are all great individualized measures and just gives you something a little bit more concrete that you can track as part of your check-ins. There's so many considerations for measure selection. People, I often refer to, I don't know if you guys are HGTV fans, but I really like House Hunters. And in that show, you know, people are looking to buy a new house, and they can usually get, you know, beautiful master bathroom or the school district they want to be in, or something in their price range. But usually it's hard to meet all of their criteria. You know, they've got to make a compromise somewhere for their dream home. And sometimes I think picking a measure is a little bit like that, because we have a lot of expectations for what the perfect measure could be for the student or parent that we're working with. And our measures are completely imperfect that are available in the field, whether you're talking about a free measure or a cost measure. So these are all considerations that you'll want to keep in the forefront, and just think through, what are your non-negotiables? You know, if you, for example, have a student in a family for whom English is a second language, you absolutely need a measure in their home language. That's a non-negotiable, right? But there may be other elements that you just can't find the perfect one. But these are all important things to keep in mind. There's other kind of MBC considerations for children and families that I think is really important. Providing a developmentally appropriate expectation. We always want, you know, students and our families to know that, like, this is not a test, there's no right or wrong answers. We want to let them know that it's normal, that they're going to have ups and downs throughout the school year. So we're not expecting our trend line to keep going up and up and up. You know, they're not in trouble if they come in. We're using this as just sort of information about whether things are going better or not as well. And the whole purpose is to talk about how they feel and how counseling's going for them, and if and when we need to change things up. So if they come in, they've been having not a great week, that's okay. That's, you know, that's, you want to invite that. And so they know they're not in trouble, they're not disappointing you. And that is going to be based on your strong relationship and rapport with them. So that's going to take some work. You want to make sure students know how to respond. And we do want to get as many reporters as we can. That's very sort of typical and classic in child assessment. And your students might be different from those whose norms were developed. So just know, if you're using a measure with norms or clinical cutoffs, those all have shortcomings. I know I have some school psychologists on the line here, so you're probably familiar with this, but if those norms are based on sort of binary gender or specific age or grade levels, you know, you may have a student that identifies differently, or is a little bit more mature or less mature than their age, or is below grade level. So those norms have limitations too, and just be kind of aware of that. Oh, here's my fun emojis. So if you're using a Likert style response and the students don't really understand how to do that, I would encourage you to just get creative, whether it's adding emojis, or I've created all kinds of different things, cups full, half full, empty, you know, and having that printed out so they can look at it. You know, so just making sure that they're understanding how to respond to the measure. And if the measure is too hard for them to respond to, it's probably not the right measure, right? It's probably not at their level. And you can, you know, you can use being in a school system, I think, to your benefit in talking about how and why we use these measures. So you could ask them, for example, you know, let's practice using these faces for something else, like your math homework last night. You know, how do you feel about your math homework last night, or how hard was it, right? And then you can ask them to kind of practice this measure and this response set in different ways, and then move them toward responding to your progress measure. Yes, good question, Miriam. So Miriam is asking if the research identifies differences in engagement and MBC across different respondent groups. So the answer is no, because I have not yet seen MBC research done with teacher report specifically. We have seen differences in when we've collected information from students and parents they have different perspectives on what the progress looks like, right? We know that. But again, I think a lot of our children adolescent research on MBC is being done in pretty controlled settings in clinics where we may have parents at a kind of a different level of engagement or partnership than we tend to see in schools. I think especially when you're talking about early intervention, you might be providing services for a student for whom has been identified at risk, maybe somebody at school identified them as at risk, and the parent may or may not agree with that, right? So we're seeing families in the school system often that are at all different phases of readiness for mental health services. So definitely a future frontier for us MBC warriors in schools. To the prior question, people are always asking about free measures. Please, if you have not signed up yet with the SHAPE system, I encourage you to go here. There is a free screening and assessment library that you can find. This is a compendium of measures that are reviewed and coded by a team at the National Center for School Mental Health. These are all free measures. A couple of them are low cost, like I think the Gain Short Screener is on here, which is a great measure. You can create an account in SHAPE as an individual, or as part of a school team, or as part of a district team, or as part of a state team. And there's a tab in your SHAPE account that says screening and assessment. So you can search for measures based on focus areas, the assessment purpose. You can filter on all kinds of different things. So please go ahead and check this out if you want to find some measures. People also will ask about if they need to use a measurement system like an electronic student data system. So we can, again, that's something we could go a little bit deeper into a part 2, but just know there is a data systems brief that was done not too long ago that would be relevant to look at. All right, I see we have some questions in the chat here. Okay, so schools conducting ACEs or trauma screens. That's a really good question. I think there's a variety of ways that schools and districts are doing this type of work right now. Some schools and districts are interested in doing sort of universal mental health screening to improve their detection of mental health needs for students who might not otherwise be identified through our typical referral processes, right? So to really sort of identify, particularly internalizing concerns for our students who might not otherwise end up in our referral pathway. That's why we would use a screening, like a universal screening. I think if you're going to do that in terms of ACEs or trauma, you would want to scale that up very slow to make sure that you have the capacity to meet that need, and we're not screening for trauma symptoms without being able to respond to that. There are a lot of resources in the implementation guidance modules and on SHAPE specifically on mental health screening. And again, we could absolutely go into that topic more in another VLS. I think another area that we see is that in the initial assessment process, when you've got a student referred to you, so now we're talking about, this is a student referred, now we're at that tier 2, tier 3 level. Someone's identified something's going on and you're doing your initial assessment. Absolutely, your initial assessment should include a trauma screen, right? Because all of the emotions and behaviors and different reasons why students could be identified for services may have an underlying trauma component. And so if you're not screening for that when you first meet a student and family, you absolutely could be missing something. Great questions. And there are trauma screens in the SHAPE library as well. This is a district example that is in the guidance modules and the curriculum, so I just wanted to point it out. One of the things that was really cool about what this group did out in California is they started at a really small scale with their progress monitoring, which is what they called it. They were focusing on tier 2 social skills groups. So they really focused it on a particular intervention to get started. And what they learned from clinician feedback is that they really needed to give some more guidance to clinicians about how to collect and actually use these measures, because the clinicians reported that they were able to collect the measures that were identified for this group, but they didn't have as much familiarity with, like, well, how do I talk about the measure with the young person? What do I do next? You know, how does this change maybe the sequencing of the social skills that I'm doing with them? Or might I need to pull in a different kind of intervention? So it was really around that sharing and acting that they found their clinicians needed more help. It was like the collecting, they were like, yeah, we collected that measure, and they were such good stewards of the data collection. But in talking to their clinicians, they needed a little bit more help with the share and the act. And I would say by and large, that has absolutely been my experience on a number of implementation projects with this practice, that, you know, we need to go beyond just the data collection and make sure that the emphasis is on ensuring clinicians have the support to do the sharing and the acting. Okay, and we have just a few minutes left here. So I just want to share with you quickly a sustainability example, because I know some of you may be particularly interested in this practice for demonstrating impact and sustainability. This was a multi-year project that I did with a pretty large suburban school system in Maryland. They had 5 community mental health agencies who had MOUs to deliver services directly in the schools. And this slide is here to show you that it really was a 3-year process to get fully up and running to full implementation. Year 1 was really a planning year and identifying goals. We did stakeholder interviews. They did want to select a measurement system that everybody was going to be using. And so that really did take some time. If you want to pick something that people are using a consistent measurement system and measure, you want to do your homework on that. And then they did some testing on a small scale before they started kind of moving up. But the cool thing is, after 2 years, look what they could say about their program. And you know, these are amazing sort of pieces of data elements that you could share to stakeholders. So they were seeing that they had, the vast majority of their students were having multiple assessments. Their effect sizes were very large, larger than is in the published literature, showing that the effectiveness of their services was quite good for pretty much all students who had more than 2 assessments. They were showing the proportion of students that were improved. They could break it down to kind of who was progressing better than expected, who was on track, and who was kind of off track. They could see that their effect sizes or their outcomes were positively correlated with the number of sessions, meaning that when students had more sessions, they were getting better, as well as being correlated with the number of assessments, which we know we've seen in the extant literature as well. So this was some of the information that this system was able to capture after focusing on implementation for a couple of years. And so I think it's a nice story about kind of the opportunity or the possibility of this practice to really promote communication of impact of services and also sustainability. This group was very important to them that they were able to communicate the importance of school-based mental health services. There was concern about pulling students out of class and instructional time to receive mental health interventions directly in the school building, particularly for students who might have been behind academically or had other things going on. So for this system, they wanted to be able to show, you know, how worthwhile their services were. So this was part of their goal for taking on this effort. And clinicians actually gave us we did a lot of clinician surveys, feedback surveys to inform how we were supporting them in implementation, but also how we were understanding the practice. And it turns out that the clinicians who were implementing really did like this practice. They saw a lot of clinical value in this. They felt like they were learning things from their students and families that they wouldn't otherwise if they had done a quote normal session, and that it really opened up the clinical conversations. And actually that piece about the normal session kind of shows up here in one of the quotes from our clinicians. And a lot of their feedback reflected that they have this combination of sort of science and art. You know, we have our evidence, and then we also have our kind of artistic clinical side, and we really need both to be delivering high quality services to young people. And so by bringing in MBC and a little bit of this measurement routine, it really kind of shores up our ability to be delivering really targeted and responsive student-centered services. So with that, I'm going to welcome, we have like 2 minutes left. So instead of additional questions and comments, what may be most useful to us in these couple minutes left is, what else do you want to know? You know, if we were going to do, let us know, are you interested in a part 2? And if so, what could we include to go deeper? Because we really did a bit of a 101 kind of survey course of MBC today. And so take a minute to let us know in the chat what else we could share with you. There are some additional slides here about questions we got on registration, which is about how to share these measures. If this is something you want to go deeper into part 2, we can do that. And with that, I just want to hand it over to Tara to do a quick wrap up and tell us about the evaluation.
Thank you so much, Elizabeth. I hope everyone learned as much as I did. So you can see on this slide, we've got our website, our listserv sign up, and our social media handles. So be sure to follow us for to get up-to-date info on the events that we'll be hosting. And on the next slide, you'll see our evaluation link, which Sarah has also put in the chat a few times. And this is the most important part of this webinar. So as part of receiving SAMHSA funding, we are required to submit data related to the quality of this event. And we ask that you please take a moment to complete this brief survey about today's session. And after you complete the survey, it will redirect you to a second survey that includes additional information our center likes to collect, and it helps us continue to improve the quality of our trainings and make sure that we're addressing the needs of our stakeholders in Region 4 through our programming. We would greatly appreciate it if you could take a moment to complete the second survey as well, and let me know if you have any issues accessing either of the surveys, and I'll be happy to help. Thanks so much for joining and participating.
Yeah, thanks for everyone's active participation today. We appreciate you, and do